So now, next on the agenda, we have John Williams joining us. John is he is the chair of the President's Cancer Panel. The three primary organizers and conveners of that panel are John and Bob Ingram and Edith Mitchell. I'm looking out there. Did Edith arrive yet? No, Edith will be here. So we have all three of that triumvirate who led the President's panel. John is a breast cancer surgeon and a patient advocate, and he has worn many hats. He's going to talk to us today about the output from the recently completed cycle of the President's panel, and it's very focused on screening, which I think is obviously very important to all of us. And John, is he in the wings? There, John, welcome.
Thank you for having me. Well, to me, it's been about 2 years this talk has been coming. As Bob and Edith and I joined the President's Cancer Panel, we had to decide what we were going to do. And I remember meeting Bob, and he was sharing with me his work with the CEO Roundtable. I had not heard of it. And I thought, what a great concept when you bring people together of different disciplines and you connect with one motivation, and when everybody's motivated for good, amazing things happen. So I would like to tell you a little bit about the President's Cancer Panel, our report on cancer screening. I want to share with you even a little bit more why I think the roundtable model is critical for addressing better cancer care, screening care, and also equitable outcomes for everyone. And I'm also going to issue a call to action to the CEO Roundtable, and that is the title of my talk. So the President's Cancer Panel is a group of three appointed by the President of the United States to advise the President and the White House on the National Cancer Program. In essence, what we do is spend a year, and we're housed with the administrative support of the National Cancer Institute, which is such an amazing body of straight, non-political, motivated professionals, the best that I've ever met. We're supported by them, but we're part of the administration. In this route, we work a year. We pick a salient topic for the National Cancer Program that needs to be addressed, and we engage the nation's experts, and we have open public meetings, and then we compose a report, present it to the President and to all stakeholders, of which you are. So the National Cancer Program is everything in cancer. So obviously that touches just about every field. But when we think about stakeholders, we think about patients first. And I'm a private practice surgeon, and that's my main mission in life and who I care for. But it's government, it's pharma, it's physicians, professional organizations, hospitals, advocacy groups, people that care about cancer in their own community, diverse groups of color, different languages. Everybody is involved in this process, from the very top all the way down to the ground in the community and in people's clinics and in people's homes. So we're all stakeholders in this. And our mission, when Bob and Edith and I came to the President's Cancer Panel, was to make, number one, try to find a way to innovate this panel. It's an opportunity to make a federal panel that most of you have never heard of important, to implement the recommendations that we make with our reports annually, and to touch people in a kind way. So let me tell you about our report. We, at the beginning of the pandemic, in March 2020, obviously everything fell through the roof with COVID, and cancer screening just stopped, essentially just stopped. It plummeted by about 90%, certainly in the first 3 or 4 months, specifically for mammographic screening, breast cancer, colon cancer, colonoscopy screening, CT, low-dose CT scan screening for lung cancer, which is new. And also for the fourth, these are 4 types of cancer that are really the predominant screening-based cancers, and cervical cancer, which is pap smears, but more so HPV testing for infection. So we realized this is the topic of the day, and why don't we study this through COVID, and we can come out of this with some innovative ideas to improve cancer screening. So we convened 4 different working groups over the height of COVID, and we immediately, even before COVID, I was like, we need to do video conferences and meet regularly, and so we'd actually started that. So we had 4 working groups: breast, colon, cervical, and lung cancer. We met, we identified the key topics that need to be addressed, and what are the deficits? Who's being left behind? And how do we address those deficits? And then we composed 4 two-day meetings. They're public meetings. They're all on our website, President's Cancer Panel. And we had facilitated discussions with experts and representatives from so many different communities, with so many different backgrounds and ideas about what is the problem, how do we improve cancer screening, and how do we attack it. We then had a subsequent meeting because my personal approach in medicine, I'm in private practice. Innovation happens on a patient-to-patient basis, and it's really more personal for me. But we in government and also in larger medicine need to innovate. And so we had a separate day meeting of innovation. We brought in the people that are thinking differently, that are challenging ideas. We don't want to do the same again and again because we'll end up with the same results. And what we found for cancer screening was we knew that we would come out of COVID and have cancer screening was already returning. But what we realized, and something that had not been addressed for decades, is how do we improve cancer screening where it's plateaued before COVID? So what we realized is that the uptake of cancer screening could be better. Breast cancer touches almost 80% of our population, 20% to go. Cervical cancer about the same. Colorectal cancer is on the upswing, and it's about 65%, still has more to go. Lung cancer, which if you are not involved in lung cancer screening, you have to take the message back to your home and to people, and that is the key opportunity for identifying people of that incredibly deadly disease and identifying people early. And we are now screening between 5 and 10% of those that are eligible to benefit from low-dose CT scan of the chest for lung cancer screening. So that's in its infancy. So we realized we need to do this better. So we ultimately put together and issued a report. And so I have a reference to it that you all have, and there's a QR link to it. But this is really a list of our recommendations, and I'm just going to walk through them. Number 1, the biggest opportunity is communication. How we need to develop effective communications about the benefit of screening to touch all populations. And that's what we realized, was that we can put an advertisement or a message on CBS, but only 60% of people are going to watch CBS. 20% may watch it now and then, and another 20% will never watch it. So the message leaves behind different groups, diverse groups. Our country's diverse. It's what makes us strong. We also need to strengthen roundtables. Now, these are tumor, and our message was for tumor roundtables. They're existing as lung cancer screening, lung cancer roundtable, and colorectal cancer roundtable. But they're powerful. I'm at the very first roundtable in cancer. You are where it all began. And it's becoming a bigger entity in our country and in cancer. And the vision of its leaders that you've just heard from moves mountains. This is our report, and we need to strengthen them, including your organization. We also recommend creating a national breast cancer roundtable and a national cervical cancer roundtable. Opportunity number 2, how do we facilitate equitable access to everyone for cancer screening? And we have to pick and choose in our report, but one of the opportunities, and this was mentioned yesterday, we have to find a funding mechanism to carry this message into people's communities by people to people that have a trusting relationship. So community health workers. In fact, we recommend finding a funding mechanism because that's how you touch people that we do not reach currently. And the biggest win is touching and bringing someone into our health system and into care and cancer care that we don't actually touch and interact with now. That's the win. And also we have to expand self-sampling or screening at home. Stool fit testing is now integrated into screening guidelines. It is a stool sample test for DNA and RNA and different factors that is incredibly effective and almost as effective as a colonoscopy, or at least identifying people that could benefit, and even more importantly, those that really wouldn't benefit from a colonoscopy. Because there's so many people that refuse, culturally, personally, to consider a colonoscopy for colorectal cancer screening. And now we're supposed to start at 45, even if you're at normal risk. Number 3, we have to expand our collaborations. And the way I think about this is, and I'm in private practice, so I know the people that work at my front desk, work with me on the intake and outtake of patients, and in our waiting area. We have to engage our population with information about cancer screening on multiple levels. It's just like advertising. It's marketing. You touch people many different times. At the right time, at the right place, the message gets through. So whether it is a brochure, whether it's on your TV, whether it's someone handing something, or outtake, physicians do not have enough time. We overtax our primary care physicians. We refuse to add to that burden. So we have to work together. And the last of this collaboration is we have to expand germline genetic testing. It is critical. There are too many people that do not get this. And we're talking about the BRCA mutation, for example. It causes breast, ovarian cancer, pancreatic cancer, and others. Or Lynch syndrome. We struggle to identify and offer testing because we can touch millions of more people and screen them and identify those that are super high risk for cancer. We also strongly recommend against the requirement of certified genetic counseling prior to testing. It's a barrier that insurance has put up. And we must do genetic testing when someone's interested with informed consent and utilize those resources, certified genetic counselors, later when they're really needed. And the last of those is that we recommend legislative action. It requires congressional action to make certified genetic counselors providers for Medicare. It'll allow these precious bits of information, we talked about it yesterday, these professionals to go into smaller communities. They're not going to be in rural communities because there's no resource. They don't bring in any income, especially for Medicare, for a hospital system to hire them. So this is critical. The fourth, and I'm going to come back to this, is IT. We can improve our IT system. We need to be able to identify people that are at risk, but more importantly, that have the get in the information to be able to tell you whether or not you benefit from getting a mammogram and when to get a mammogram. So our electronic medical records use the guidelines that exist. American Cancer Society, United States Preventive Task Force, they make the main guidelines for determining whether someone, what are the guidelines for breast cancer screening, colorectal cancer screening, lung and cervical. And the last is we have to make these guidelines, these important bodies that spends, and they're all volunteers essentially. And we've had meetings with the chairman of the United States Preventive Task Force about this. And I just had an in-person meeting with the leader of this for the American Cancer Society. They love the idea of making guidelines computable. So pen and paper, when to get a mammogram. Do you start at 50? Or do you start at 45? Are you at high risk? Do you get it every year, every other year? In the past, we all know that if you're 40, get a mammogram once a year. It was simple. Now, all four of these guidelines are incredibly complicated, and no one can really commit them to memory and have too many people come in and never get offered screening. So all of those recommendations are on this sheet. But what I would like to do is focus on a call to action for the CEO Roundtable. And in that call to action, there are three things that I think that are important, and they're opportunities to develop actionable deliverables. And you're all in business. Many of us are in medicine, but deliverables is something that you understand, and what you just heard Mr. Murphy say. So Mike, I have 3 call to actions for all of you, not only as a group, but also for your organization and individually. Number 1, for the CEO Roundtable. I would like to see you expand your organization. There's a power in roundtables when we connect the dots and we inspire one another. We also bring different talents and resources together. You're seeing it in action here. We are spending a great deal of time expanding tumor roundtables for our country through the American Cancer Society. Edith Mitchell and I will be on the breast cancer roundtable. I have the privilege of co-chairing it. There's power there, there's influence there, there's action there. So I would love to see the individual companies bring new members here. Members also to financially support the roundtable so it can expand its mission and its implementation of what's needed. Number 2, I would like to see the CEO Roundtable become more visible. In medicine, we struggle with communicating, and we are less effective because we don't communicate what's needed. And I would love to see the CEO Roundtable, everyone know about it. And one opportunity was just an idea, is come out of your annual meeting, and I'd love to see this roundtable follow its leader and its board and put a flag in the ground and say, we just spoke about accelerating healthcare, equitable outcomes. This is what we think needs to be done, and we're going to stand behind it. And when you do that, there's substance in all of your work. And I think that that's an opportunity. I have 3, which is actually my real significant ask. Our report became part of it was released on February 2nd in concert with the White House as part of the new Reignited Cancer Moonshot. So Dr. Mitchell and I were there for that event and also both spoke to the President and the First Lady. The cancer screening aspect of the new Moonshot, you're looking at. This is it. And actually, there's no other real component of the Moonshot that's really written down. They've incorporated this. The timing was right for this report. There is, as I go through this report, and I said I would return, my call to action for you as a body, and you all individually, especially with your organizations, have the capability to help us, or shall we say the CEO Roundtable, make cancer screening guidelines computable. So let me explain. This is a one-time effort, but the problem is that when you have the 2 bodies, the American Cancer Society and the Preventive Task Force, and they make these pen and paper guidelines, they're just half a page. EMRs identify to run you through your information and offer you a mammographic screening. But it's proprietary. If we have these guidelines written in computable format, basically taking the written word and putting it in an Excel spreadsheet, but it takes time and it's detailed work. But it's actually what so many of your companies do every day. This is real simple stuff. And give it to the ACS and the Preventive Task Force, and they post it online as they do with their written version. It's powerful. Anyone that's writing a program can just download the information. Every year from now going forward, they will update that in electronic format. It's easy. They will do it. And it will accelerate the implementation of cancer screening that currently is at a plateau. We have to do something different. So my challenge really is that we have a cancer screening guideline liquidity problem. And that was said, I think, yesterday by Tim. It's just not provided. And the people on both panels are volunteers, essentially. And they don't know how to do that. So I challenge you, if you're interested, and I also challenge if you really support what we're all trying to do. This is a minimal effort, but I challenge you as organizations to join me with the roundtable. And I'll guarantee 3 years of my time and some of the experts that wrote our President's Cancer Panel report on this section to work together. And also you all have the resources and the expertise even within your organization to help us create one-time cancer screening guidelines that then perpetually be available to future generations. Otherwise, it's going to happen organically over the next 20 years. That's too long to wait. We've already been using EMRs for 20 years, and they're still poorly integrated into this. So, 3 call to actions. 1, I would love to see you expand, but it really is up to the members to bring new members, members that pay dues to strengthen this organization. 2, be visible. Put a flag down. That's when it means something, when you stand behind it. Otherwise, it doesn't stand for much more. And number 3, it's time to provide seed funding for the good. And that good is to help us, help the White House, help the moonshot. This is right part of this program to accelerate. And as we learned from COVID, cancer screening was very elective during the height of it. But I challenge you to help us make cancer screening never elective again. So thank you for your time.